So this is a very good question you ask for. My experience and the experience when I am working with the speech therapist from the 11 years, I realized that they know more than doctors knows. Dentists, orthodontists, we just focus on the structures. The orthodontics mostly focus on the structures. Dentists also, they don't have time just to manage so many things. But neurospeech therapists, they are crazy about the tongue. So the tongue is so much important things in the orofacial system. I hope that I will show you that, and I agree that there is a lot of children that will be born by cesarean section, but we have to tell people that that has disadvantages also. So if they just overact for pain and they afraid of pain, it's worse to tell them that it can have it can have the negative effects for the children, and those small children many times needs a support. They need the stimulation, and they need to go to the physiotherapist, the neurospeech therapist to make the stimulation, because you can stimulate also and support development of the child when you just stimulate the endings of the cranial nerves, and when you just are focusing on the tongue resting position on the palate, because the tongue resting position on the palate is very important, because you have some receptors on the palate, and there is a proprioception who goes to mesoencephalic nucleus of the trigeminal nerve. And this Baron and Mayer, they describe the homolateral pathway. So if you stimulate only one side, so if the tongue have the contact with the palate at the one side, they will put the information to this trigeminal nucleus, which is the inside the brain, and it is not outside where are the nucleus of the other cranial nerves. And it makes so important of that trigeminal nerves. So I hope that I will explain more if you will see my next presentation. If you will stay, I hope that you will stay and you will listen. So mechanotransduction, the process by which the muscle and bone cells respond to mechanical stimuli, plays a fundamental role in regulating the growth and remodeling of the stomatognatic system structures. The tongue not only shapes bone structures through pressure and mechanotransduction, but the tongue also requires proper stimulation for his own optimal growth. So we have to focus how to ensure the tongue the proper growth, and we have to focus on it from the birth, from the early stages of the human life. So the first peak of human growth occurs from birth to 1 year of age, during which the early etiological factors impact craniofacial development and the potential for the malocclusion, and the tongue grows significantly during early childhood, with the anterior region reaching adult size by 8-10 years of age, and the posterior region continuing it to grow out in 15-16 years. The tongue is an organ composed of muscles that are connected to the bony structure of the craniofacial region and neck, but the entire structure of the tongue is additionally enveloped by the continuous tissue, slightly continuous elastic tissue called fascia, or muscle connective tissue. And this tissue is so important. This tissue connects whole body from head to toe. So the tongue is connected to all structures in our body. And when you sit now, and you can sit properly, straight, and you will just try to imagine where is your tongue in the mouth, and when you up the, just try to do this exercise, please. And when you lift up the legs, just notice what is happened with your tongue. Probably it goes down because of that connections. So when we examine the in 5 scale of MFS philosophy designed by Professor Duran, we use this scale. Patient is open maximum his mouth, and then we check how the tongue is elevated, and it is symmetrically elevated or it is deviated also for some part of the oral cavity. So muscle activation promotes elongation, development, and the influences both strength and range of tongue motion. A key movements include concentric, eccentric, and isometric contractions, maintaining a resting position, which strongly stimulate muscular adaptation and the synthesis of myofibrillar proteins. The tongue as the skeletal muscle follows the same principles of the growth and biomechanic adaptation as other striated muscles, and connective tissue plays a crucial role in regulating myogenesis and muscle morphogenesis, and interactions between muscle connective tissue and muscle are essential for morphogenesis and the formation of cranial muscles. And under optimal conditions of initial muscle stretch, the maximum overlap of actin and myosin filaments within the sarcomere occurs, and it allows to the formation of more cross bridges and ensuring the highest contractions efficiency and determines the force generated by the muscle. And this muscle connective tissue guides the migration of muscle progenitor cells during embryogenesis. So at the beginning, there is the muscle connective tissue. Then it is the muscles are just formed. So fibroblasts of muscle connective tissue secrete signaling factors influencing the proliferation and differentiation of myoblasts and interact with myoblasts through the transcription factors and regulate muscle fiber formation and force epimysium, perimysium, and endomysium, providing shape and structural organization to muscles, and collaborates with satellite cells in the process of muscle regeneration also. So the entire structure of the tongue is enveloped, as I say before, by this muscle connective tissue, and this muscle connective tissue, it is continuous tissue. When you see this coronal section on the ventral tongue and floor of mouth, you can see there is a continuous tissue, and that tissue is suspend the genioglossus muscle, the submandibular glands, submandibular ducts, and it is not a string or band forming the frenulum. This is a continuous tissue, and this continuous tissue, it is attached to the periosteum. It is attached to the periosteum, covering the inner surface of the mandibular body. As you can see, these are the research of Nikki Mills from New Zealand. She in 1219, she discovered that there is a no string or band, that is a continuous tissue, and this continuous tissue envelop the tongue and also create the floor of mouth fascia. The range of tongue mobility is influenced by the facial dimensions of the floor of the oral cavity, and the range of tongue movements within the oral cavity reflects the properties of the fascia, its elasticity, which allows for achieving a certain limit of movement, the critical value of tongue movement at which the fascia undergoes tension determines the end point of the tongue. And based on the topographic anatomy of the tongue and the floor of the oral cavity, supported by Mill's research, the surgical approach in the MRT technique, when proceeded by frenulotomy, involves incising the mucosa and fascia, both anterior and posterior to the duct of to the ductal of opening of the salivary glands. Sometimes I thought I just cut only this posterior part. And why? Because we have to avoid the nerves, which are here and here, this duct of the glands, and here you see the branches of the lingual nerve. So we have to avoid those nerves when we doing frenulotomy. Designed to activate fibroblast growth factor, promoting proliferation and metabolic transformation, and influences fibroblast activity, leading to increased collagen synthesis and the extracellular matrix remodeling. And it is supported by studies on a soft tissue mobilization and fibroblast activation. And preparation for the MRT technique, it is the interview and assessment of the tongue frenulum in the context of its morphology and function, and use of tongue mobility assessment scales using the Duran classification, and application of preliminary stimulation as preparation for frenulotomy. And the technique involves using a tool in the floor of the oral cavity and the ventral surface of the tongue. The tool is made of stainless steel and is available both with the pressure control and with pressure control ranging from 0.5 to 1 Newton. And I would like to show you those tools. And we can use it inside the oral cavity just to improve the tongue movement, just to improve the elasticity of the floor of my mouth fascia with frenulotomy or without frenulotomy, if the range of motion of the tongue is not so much restricted. But as you can see, we can also use in the scarring process, as for example, of the neck of this lady. I will show you later what is the final result of this stimulation, what we achieve after the 1 year of the stimulation. And I have the So this is a very important, because if we use the manual tool without the possibility to control the force, sometimes you have to believe that how they will use this information. And in many cases, that probability is not so accurate. Okay, and I have some videos to show you how we use this tool in oral cavity. This one, it is without the control of the pressure. And as you can see, you have to believe that the parents or the patient will do that properly. And here you can see that we can use it also with the tool. Here it is 0.5 newtons, And we stimulate the all of floor of mouth fascia and also under surface of the tongue. And also the last exercise, it is I press inside the mouth to the tongue and patient press outside, and we keep it for the 10 seconds. It's very important to keep it in a 10 seconds. Okay. And I would like to show you the case. And I would like to ask you the question. Maybe someone will can answer. Does the crossbite correlate with tongue deviation? Is the unilateral deviation of the tongue a coincidence or a key diagnostic signal? Someone can answer for that question. Okay, no problem. When you see that patient before treatment, it is the patient with the lateral crossbite. It is my patient. I was treated him orthodontically with the one appliance, upper arch appliance with torque individualization. So in my treatment plan, I want to correct this. Problem, but I also recognize that this patient, as you can see, when he's elevated the tongue, his tongue is deviated to the left, not symmetrically, but it is deviated. And when it is deviated for the many times during a day, when he's just chewing, swallowing, and using the tongue, it is why it is not properly stimulate to mechanotransduction process of the right side, and this is why he has the crossbite at the right side. So we made the frenulotomy. As you can see, after the procedure, asymmetry in tongue positioning during vertical movement is still presenting, along with the bifurcation in the mass of the inferior longitudinal muscle. So the surgery doesn't resolve the problem. So surgery, it is not enough. So we need to implement some treatment just to improve the tongue movement. And you can see after approximately 3 months of stimulation with the MRT tool, vertical upward movement shows smooth tongue elevation with the symmetrical distributions of muscle mass and absence of compensatory movements in the facial muscles of the lower face. The effortless tongue suction to the palate. And finally, after about I don't remember exactly, but you can see that he can open maximum. He can move the tongue slightly. He can just put the tongue on the palate, and it doesn't make any problems for him. So we resolved the problem by orthodontic treatment, and we also did the surgery. This is how this patient looked before, after surgery, when his tongue is elevated, after 2 months, and after 7 months of the MRT technique treatment. And this is the case. I want to show you that we use the MFS protocol of diagnosis and also the implementation of the MFS antibruxismus device and the myofascial release for the tongue to achieve the better strength of the muscle tongue, and also to achieve the tongue resting position on the palate. And after 2 years of that stimulation, we achieve the normal occlusion. It was second class. And now we have normal class, and we have a not so deep bite as before. So you can see it was no surgery, but you can see that what kind of movement it was before. The bifurcation, not symmetrical movement of the right and left part of the mass of the tongue. And then after about 1 year of the MFS without surgery, we achieve this, and after 2 years from here to here, from here to here. The CISL suggests that airway obstruction may cause contraction of the posterior fibers of the genioglossus and hyoglossus muscles on the both sides of the tongue, and this is accompanied by the contractions of the mylohyoid muscles forming the floor of the oral cavity, and this activity may be associated with the mouth opening and the inhibition of the antagonistic jaw elevating muscles. The change in tongue position is generated by sensory stimuli from the larynx pharynx to maintain the patency of this alternative airway. And here I want to show you how, and this is why we just focusing so much about the breathing functions also. The breathing for us is the most important. And here you can see the patient before. And all of the specialists who see that patient, they say they need a frenulotomy, but we restore the nasal breathing and then make the implementation of myofascial release technique with the tool. And after 3 months of that treatment, you can see what is the improvement of the nostrils width and also of the tongue movement. And the same improvement of the tongue movement we can see in that adult patient. A change in breathing pattern, relaxation of the oral cavity fascial floor, and improvement of tongue mobility, achieving without surgery, but only restoration with the nose stimulator and the MRT technique for the tongue. And here the case of 7-year-old boy, final project of the MFS modular training participant, neurologopedist Maria Wisnerowicz, the improvement in tongue mobility and oral cavity opening. Additionally, after 4 months of therapy using the obturator and nasal stimulator to restore nasal breathing and MRT technique tool, the long-awaited R sounds and the sibilant series appeared in speech. A significant reduction in under A bags was also observed. And this patient snoring during the night and with the nose collapse, it is the one of the what we diagnose in the MFS philosophy. How, what kind of nose collapse is in a patient. So the patient said that you cannot breathe halfway, a little, or sometimes. Breathing is life, and now I finally live the 100%. And you can see before and after the using of the nose stimulator and just improvement of tongue mobility with the MRT technique. The words of 39-year-old patients summarize the essence and the outcomes of the therapy based of the MFS philosophy. The therapy is ongoing, and goals set at specific time intervals have allowed the patient to gradually experience changes and fully accept them. These include the improvement sleep efficiency, significant enhancement of primary functions, increased physical performance during sport activities, higher quality of life in social settings, overcoming shame and social withdrawal. In summary, the patient himself expressed red lines to address future morphological and functional disorders. And you can see also how improved the tongue movement after restoring the nasal function and also the myofascial release technique for the tongue. According to the Hagen-Poiseuille law, the airflow through the nose is proportional to the radius of the nasal passage and increases to the fourth power. As a result, even minor changes in the size of the nasal value, such as 1 millimeter, will affect airflow resistance in the nasal cavity. The proper nasal values The proper nasal valve, yes, proper nasal valves have sufficient stiffness to prevent nostril collapse during the inhalation when the patient breathing. According to this law, increasing the radius by 10% result in an improvement in airflow, increasing it by half. When the tongue is positioned on the palate, the periodontal receptors are stimulated, and this sensory information travels to the central nervous system and providing critical input about the position of the muscular structures above and below the hyoid bone. In response, the muscle group innervated by cranial nerves are engaged, ensuring the functional coordination, and spinal and cranial nerves are interconnected and facilitating a neuromuscular feedback. And this is why we are so much crazy about the tongue, because the cranial and spinal nerve has this mediator. It is a tongue resting on the palate and acting properly during this position, and this is so much important. And the tongue transmits proprioception to the trigeminal nerve in two ways: through its own muscles, spineless and mechanoreceptors, deep sensation of the tongue, and through contact with the teeth and periodontal mucosa, which also convey information about the tongue position. In summary, an incorrect resting tongue position and open mouth may indirectly affect the function of cranial nerves, third, fourth, fifth, sixth, and 11th, through changes in muscle tone, proprioceptions, and motor coordination. The MRT technique in practice indications for the use of MRT tools: pre-frenulotomy to stimulate the fascia and prepare tissue for the procedure, post-frenulotomy to improve tongue mobility, prevent scar formation, and stimulate tissue proliferation for optimal healing. Without surgical intervention, in cases of tongue mobility, diagnosis as a level 3 Durant scale, enhancing myofascial elasticity and improving tongue functions, and supporting proprioceptions and neuromuscular control to optimize movement patterns, reducing compensatory muscle activity in the lower facial region. Scar tissue mobilization, MRT can also be applied in cases of restrictive scars in other areas of the body to enhance tissue flexibility and function. Mobilizing the tongue with varying tool pressures to achieve functional and structural adaptation in the fascia and muscular system. MRT technique is approach that support both pre and post-surgical therapy, surgical functional improvement, and scar tissue treatment. As I promised, I would like to show you also the results of using that tool in scarring process. And this is the patient, and this is how we use the pressure. At the beginning, we use the smaller force, and then we just improve the force. At the beginning 0.5, then 1 Newton per square millimeter, and before and after 1 year we achieve these results. We published some articles about this technique. And at the end of that presentation, I would like to show you also the patient. And you can see that because of the mouth breathing problem, because of the low tongue positioning, and because of the shortened frenulum, she had the dolichocephalic pattern of growth. She has the tongue thrust. She has the low position of the tongue. She has an open bite, and she has the opal-genial angle, as you can see here. And we use to restore the functions. We just focus on restore the functions. She comes to my office, and she goes also for neurospeech therapist, and she work with us together. And after the some period of that treatment with the frenulotomy, with the use of tool for myofascial release technique, this is the scar after the 1 month or 2 months of the surgery. You will see under the tongue this scarring process. And after the treatment with the tool, you can see that there is a tissue proliferation of the tissue here, and the tongue mobility is improved. And we also restoring the function. We give the new guidance for the bone. As you can see, she after some years, she achieved the normal weight only for this functional reeducation. As this is the face of that girl after the following therapy, after following checking, we just check if everything goes right. I would like to ask you, maybe you have some questions. Thank you so much.